Dear colleagues, good evening. Alexandra Masson-Lecomte from Paris. Thank you very much for being there. She's professor of urology at Paris Cité University. And we have with us also from the Netherlands, and we are super happy to have you, is Toine van der Heijden. I hope I did say your name correctly. From Radboud University, Nijmegen. Am I correct?
Nijmegen.
Nijmegen. I'm trying to improve. So guys, we are going to have a good debate tonight, good for the topic, because for many, many years we have been doing cystectomy in muscle-invasive bladder cancer. The concept of systemic treatment as a neoadjuvant treatment before cystectomy has changed the guidelines a few years ago. But now we are also sticking with much more accurate, I would say, stratification of the disease, even after the neoadjuvant chemotherapy. And the question is whether or not we can, in certain cases, avoid cystectomy. So let's have the vision from you, Toine, and then we will ask Alexandra to present her data, and we try to find, I would say, a good take-home message to send to our colleagues. So thank you, Toine, and the floor is yours.
Thank you. And I have the opportunity to have the pro. So yes, we need to perform a radical cystectomy for patients who are clinically T0 after neoadjuvant chemotherapy. I have no conflicts of interest regarding this presentation. And the question to be answered. The question we want to answer today is whether we should perform a radical cystectomy in patients who are clinically T0 after neoadjuvant chemotherapy. Or is it possible to preserve the bladder in these clinically T0 patients? And to date, the standard of care has been cisplatin-based neoadjuvant chemotherapy followed by radical cystectomy. And this treatment is actually the best way to maintain long-term survival. But what is the role of a radical cystectomy as standard of care in patients that achieve a complete clinical response after cisplatin-based neoadjuvant chemotherapy? And actually, that's quite a complicated question, because everyone wonders, when you have a complete response on imaging, why do we need to perform such major surgery and remove the bladder completely? Because our optimal goal should be to avoid actually the complete removal of the bladder. But how can we accurately evaluate if a patient is a true complete responder? And besides that, it's I think very important to realize that patients are offered a one-size-fits-all chemotherapy schedule. And chemotherapy has shown to be effective as neoadjuvant treatment, but chemotherapy alone is not sufficient to treat bladder cancer. And when we look at the guidelines, and we take, for example, the AUA guidelines, then the guidelines say to perform a radical cystectomy as soon as possible after neoadjuvant chemotherapy. And if you want to perform a bladder-preserving approach, think of trimodality treatment, but not about a maximum TURBT or partial cystectomy or radiotherapy in patients with urothelial carcinoma. And chemomonotherapy is even not mentioned. Looking at the EAU guideline, the 2023 guideline, the recommendation is very clear: do not offer chemotherapy alone as primary therapy for patients with localized bladder cancer. When we look at the schedules, the cycles of neoadjuvant chemotherapy, and this is actually not in a group of patients which normally get neoadjuvant chemotherapy, because these were patients with advanced urothelial carcinoma, but you can see that there is a difference when you give, for example, 3 to 5 cycles or 6 to 9 cycles. So I think we have to conclude that 3 or 4 cycles of neoadjuvant chemotherapy is not enough to have a conservative treatment. How can we clinically stage patients? Actually, this is the biggest problem. In, for example, prostate cancer, we have nowadays the MP-MRI and the PSMA PET scans to stage patients, and we can do that before and after treatment. But this is a solid tumor. In bladder tumors, this is different. And in bladder cancer, we are far not there. In bladder cancer, it's even more difficult to evaluate response after treatment compared to untreated bladder tumors. The question raises whether we have to prove a complete response histologically. And if we do have to evaluate that, how should we do that? Is, for example, a cystoscopy plus cytology enough? Or can we use urinary markers, for example, EP check or expert bladder detection? Or should we take biopsies and prove it histologically? And if we do so, how deep should we go with these biopsies? Or do we need to do a complete resection of the resection bed into the perivesical fat tissue? All questions we have to answer. And if we look at this study published in 2021 in European Urology, a study by Becker, it's about clinical restaging and tumor sequencing as inaccurate indicators of response to neoadjuvant chemotherapy. What they did is patients were treated with neoadjuvant chemotherapy. They performed a cystoscopy and afterwards a TURBT. In 114 patients eventually underwent a cystectomy. And what we see is that the negative cystoscopy still 41% had residual disease on the TUR or on the cystectomy. When we look at TUR sensitivity to predict residual disease, then in 27% it was more than a PT2. In the end, 41 patients, 37 tumors were downstaged, and 4 patients had node metastasis. And if we exclude all patients that had insufficient chemotherapy, 28 of the 96 were falsely downstaged. Tumor sequencing did not make a difference. So in the end, the conclusion is that restaging after neoadjuvant chemotherapy is not to be used to justify the deviation from the standard treatment, and that is cystectomy. But what would come out if we wouldn't treat patients with a cystectomy after neoadjuvant chemotherapy? This is a conservative management following complete clinical response to neoadjuvant chemotherapy, and there's a study from Mazza, published in 2018. What they did is 148 patients with a complete response were evaluated retrospectively. They had 55 months of follow-up. Patients elected not to be operated, and they were treated with at least 4 cycles of neoadjuvant chemotherapy. And what you see is that 48% of patients had a bladder recurrence, 16 invasive and 55 non-invasive. And salvage cystectomy prevented 22 of the 26 cancer deaths. And in the conclusion, they say 11 could have benefit from immediate cystectomy. And if you count that, that's about 7%. So the added mortality by the conservative approach here is 7%. And actually, that's more or less what we gain with neoadjuvant chemotherapy, 5 to maximum 8%. And the undetected non-responders to neoadjuvant chemotherapy do bad. We know that. This is a study, survival of patients with muscle-invasive bladder cancer. This is from the National Cancer Database. And we see here in the purple dotted line that patients treated with neoadjuvant chemotherapy and the cystectomy afterwards, who were less than PT2, did significantly better than patients who had neoadjuvant chemotherapy and a radical cystectomy with PT2 in their specimen. That's the pink line. So you see a big difference between those lines. And we have to conclude that patients who have still more than PT2 disease after neoadjuvant chemotherapy do considerably worse than patients who have less than PT2. And then the near future. What are the new imaging techniques? To my opinion, our imaging studies, the standard MRI or CT scans, fail to adequately predict the presence or absence of disease. Under and overstaging is a major issue here. And what's the value of that post-neoadjuvant chemotherapy CT scan or pelvic MRI? So if we want to go to bladder preservation, we should first improve these techniques. And until that point, we can only prove complete response by completely removing the scar into the perivesical fat tissue. And if you want to be predictive, maybe you should also bladder map and see if there are other lesions in the bladder. But there are promising new techniques, such as, for example, the FDG PET scans, and the MP-MRI, or a combination of both techniques. First, an FDG PET-CT study, where they looked at residual tumors after TURBT. Patients were treated, 97 patients were treated with a TUR, afterwards a PET-CT, and thereafter a re-TUR. 98 lesions were discovered, 64 had residual tumor, and 34 had inflammation. That's the pitfall actually of an FDG PET, that you find also a lot of inflammation, a lot of false positives. The prediction of the low, the intermediate, and the high-risk residual disease was about 40, 85, and 98% based on the combination of the submean and the lesion thickness. Then the MRI for response evaluation. Actually, I love the MRI because, to my opinion, this will be the future. To make a multi-parametric MRI of the bladder, use the virus score to predict if the tumor is invasive or responds well or not. So MRI is not advocated for all patients with bladder cancer, but MRI is very useful in the differentiation between a T1 and a T2 tumor. Actually, a study that's running in the Netherlands, the blood paradigm study, will focus on this. And also for determining the response to chemo or immunotherapy and after bladder sparing approaches, such as trimodality treatment. And then the markers, also the near future. There are a couple of ongoing prospective trials on bladder preservation and the use of DNA damage response gene alterations. And actually those studies use that to select patients for cisplatin sensitivity and bladder preservation. But what is the place of these genomic biomarkers, RNA level or gene sequencing level? Does it improve our clinical staging? And is it better to use that, or should we stick to imaging techniques such as MRI, CT, FDG, PET, or combination of these with biopsies? To my opinion, markers are the future. And compare this, for example, with breast or lung cancer, where molecular staging is an important part of the treatment. And we need to come up with a molecular signature to prove that complete response. And if we do so, we still don't have a pathological proven complete response. But when we have a complete response on imaging together with a gene signature that is highly likely to fit a complete response, I think we can avoid radical cystectomy. Some markers for neoadjuvant chemotherapy response prediction are the genomic analysis, a 3-gene signature that predicts a response and overall survival in a small group of only 34 patients, but it's promising. Then the ERK study, ERK and neoadjuvant chemotherapy. ERK alteration was seen in 36% of 25 responders versus 0% in 25 non-responders. And there was a correlation between the response and the overall survival, both in discovery and the validation set. Then the basal subtype responds better to neoadjuvant chemotherapy, is basal versus the luminals. and the defects in DNA repair genes that predict better response to neoadjuvant chemotherapy. But I think we have to beware of heterogeneity. So the tools are there, but we have to combine them and have to beware of the fact that bladder cancer is a heavily mutated cancer with a high level of heterogeneity in the tumor and also in the rest of the bladder. So if we do an assay and if we see DNA repair mutations, does that mean that there's not only a clone within the bladder that doesn't have these mutations? Those are questions we have to ask ourselves. Then some current trials. First of all, the RETAIN study. The RETAIN study is a study with a combination of biomarkers and clinical staging. Actually, in the ESCO 2023, there was an abstract that shows that the metastasis-free survival was 67% in the intention to treat versus 65% in the active surveillance group. And there were no association between the mutations and the metastasis-free survival. Then we have the study of the Alliance for Clinical Trial on Oncology. Patients whose tumor contain delaterations, alterations in any of 9 pre-selected DDR genes and who exhibit less than T1 response on clinical restaging were eligible for organ-sparing management, and we have to see what comes out of this trial. Then the third trial, the pre-prevention trial, is a Dutch study, just recently stopped recruitment. We have to wait for the results. And last but not least, the MAINTAIN study, a study with a PET MRI to evaluate response to neoadjuvant chemotherapy. And I want to show you 2 slides of that MAINTAIN study. It just finished, only included 12 patients. Patients were treated with cisplatin-based chemotherapy and afterwards a cystectomy and underwent a water-traced PET MRI just before the neoadjuvant and after the neoadjuvant chemotherapy. And what they did is they compared the MP-MRI figures on the left-hand side, where you see that there is a massive decrease of tumor load in that patient. It was not completely, at least the radiologist thought it was not completely and marked a small part. But when you look at the water-traced PET scan, you see that there was no blood flow anymore. So the PET scan shows actually a complete responder, and the MRI had some doubts, but in the end, this patient had a complete response. This technique is not perfect yet, but it's maybe the real future. So in conclusion, of course, you can do bladder preservation, and it can go well in selected patients. But the loss of 7% added mortality nullifies actually the gain we have with neoadjuvant chemotherapy. And that's beside the chemo issues, staging limitations, and follow-up. So patients with a clinically T0 after neoadjuvant chemotherapy at the time of cystectomy is still the standard of care. And there will be in the near future a cohort of patients, and I'm sure that we can preserve their bladder. But to my opinion, we are not there yet. We should be honest to patients to inform them about the standard of care. And that's actually the radical cystectomy. But if a patient wants to face the benefits for neoadjuvant chemotherapy, they still have to go for that. And that's going to provide them the best chance of a long-term survival. And we have to inform them that there are some trials and trial-based settings that are alternative ways to approach muscle-invasive bladder cancer and to preserve their bladder. Thank you.
Thank you very much for your presentation. But from your lecture, we can understand that there is probably room for improvement in the stratification of this patient. So Alexandra, you will try to push the point of view of going into the direction of avoiding cystectomies. Of course, systematic, I would say, mechanism of neoadjuvant or radical surgery is not always the good way to go. So what can we see from the current practice and the guidelines, and where can we move forward? Please let us know.
Yes, thank you, Morgan. So I will defend conservative approaches in the upcoming 20 minutes. So I don't have any conflict of interest for this presentation. I'm not selling radiation devices. And I think it's very important before starting the talk to understand that there are two completely different clinical scenarios in which you might want to consider bladder preservation for urothelial carcinoma. The first one is the setting of a unique, rather small, or at least not too large, completely resected cT0 or maybe very small T3, it's always difficult to tell on the CT scan or the MRI, with no diffuse CIS, with no hydronephrosis. And for those patients, you can consider upfront trimodality therapy with TURBT plus radiochemotherapy with excellent results. And I will show you the data on that. And then you have a completely different situation where you have upfront any T2 to T4 localized urothelial carcinoma of the bladder. So not those very highly selected ones you see on the left, where you are going for neoadjuvant chemotherapy using 4 to 6 cycles of MVAC or GC, depending on the part of the world you are working in. And then you decide to go for bladder reassessment after neoadjuvant chemo. And I completely agree with what was said. We still need to improve on that. And for which you have complete clinical response, which again still needs to be properly defined and validated. And in this situation, you might consider bladder preservation based on response to chemotherapy and not based on the initial characteristics of the tumor. And this setting is very important because the impact of complete response on survival is absolutely major. Out of all the prognostic factors we have in bladder cancer, being a complete responder to neoadjuvant chemotherapy is one of the strongest factors associated with survival, with patients that in all the cohorts, prospective cohorts available, have 5-year survival that is above 80 to 85%. So this is really a population in which we might want to consider treatment de-escalation. So I would like to start and illustrate what I'm going to say later with a little clinical case, which is one of my patients. He's 68 years old. He was referred to me in 2017, so I now have quite a long follow-up. He was an active smoker. He had myocardial infarction in 2013 and some peripheral arterial obstructive disease. This was a single patient, a little bit isolated, and he had very severe low urinary tract symptoms that were resisting to medical treatment. So he was referred to me with a CT scan that found a rather large, you will see the images, right lateral wall tumor with multiple bladder diverticulae. There was no hydronephrosis, no sign of Mets. He had good GFR and cardiac function. And I did my best, but my initial TURBT was clearly incomplete, mainly because first off, all the diverticulae he had, and because I had the impression that the tumor was infiltrating in the fat, in the perivesical fat. And it was a pure urothelial carcinoma, T2 on the TURBT with CIS. So here are the CT scans of this patient. I will show you the one on the right because we see better. So you will see on the bladder wall on the right, you see it's a rather large tumor. There were the diverticula a little bit everywhere, as you can see here. And so it was quite challenging and I could not resect the tumor completely. So I think everyone would agree that this is not the best indication for a bladder sparing approach. My TURBT was incomplete. The tumor is really large. There are diverticulae everywhere. The patient has severe low urinary tract symptoms that improved a little bit after the TURBT, but it was not perfect. And so we first went for a standard treatment for this patient and went for 6 cycles of MVAC that he tolerated quite well. But what happened at the end of the chemotherapy, which actually happens sometimes, is that the patient started asking about bladder preservation, and he didn't really want to undergo a cystectomy after the chemo because he was tired, as this usually happens. And so he was asking. And So we decided, since he was refusing the radical cystectomy, to go for a new TURBT. And I was quite surprised to see that this patient was a complete responder. He had an almost intact bladder. It was like he never had any bladder tumor. So I performed an MRI because I use it in my daily practice, and I completely agree with what was said. MRI is a very, very useful tool to evaluate patient for response to neoadjuvant chemotherapy. In my point of view, it's even more useful in this setting than the initial VIRADS setting to identify Masson invasive tumors. And there was no sign of residual tumor on the MRI. So complete response on the cystoscopy, complete response on the TURBT. There was no tumor. I resected the tumor bed, and there was no sign of residual tumor on the MRI. And this is a situation where it starts to be quite difficult to tell the patient that he still has to undergo radical cystectomy. So we did not. And we did radiochemotherapy instead. He had 2 cycles of 5-FU mitomycin because he already had 6 cycles of cisplatin, so he could not have more. It was well tolerated, and I have been following this patient since September, since 2017. I saw him last month. His cystoscopy is absolutely perfect, and you will see the MRI. It's almost like this patient never had a bladder tumor. He still have those diverticuli on the bladder wall, but otherwise his bladder is absolutely perfect. All the low urinary tract symptoms disappeared after the neoadjuvant chemotherapy. And this patient is extremely happy. So I'm not trying to generalize this patient to any patient, but I absolutely need to strongly disagree with this 10% overall mortality that was stated before, because we have no high-level prospective evidence comparing radiotherapy to radical cystectomy. So if you want to say that a treatment is superior or inferior to another one, you need to prospectively compare them. And this has never been done for radiotherapy and radical cystectomy as local treatment for bladder cancer, and it will never be done because it's unfeasible. The SPARE feasibility trial was conducted in the United Kingdom. They had to include, to randomize 110 patients between radical cystectomy and radiotherapy to treat their bladder cancer over a 2-year period, and only 45 patients were included over 30 months. And the main reason is that patients do not want to leave the choice of local treatment to chance. They want to choose. Some want to choose cystectomy. Most of them, if you have a bladder sparing approach, the patients are going to go for the radiochemotherapy, and this is what happened in this trial. So I think it's really important to have in mind, we do not have prospective comparative evidence. So you will have to look at the radiotherapy cohorts I'm going to show you, keeping in mind the results of survival after neoadjuvant chemotherapy and radical cystectomy, and keeping in mind that they are not directly compared, and it will not be done. Radical cystectomy, even if you perform neoadjuvant chemotherapy before surgical treatment, is far, far from treating and curing all the patients from bladder cancer. If you look at the Grossman, very famous neoadjuvant cohort from 20 years ago, the overall survival with neoadjuvant chemotherapy plus radical cystectomy at 5 years was 57%. So almost half of the patients were dead of the disease. And if you could say that this is 20 years ago, so this is outdated, but when you look at the VESPER trial that was published last year, this year in Journal of Clinical Oncology, presented last year at ASCO, when you look at the PFS, so it's not overall survival, it's progression-free survival at 3 years between the gemcisplatin and dose-dense MVAC group, it's between 56% and 66%. So even in contemporary series of patients receiving 4 to 6 cycles of neoadjuvant chemotherapy, you still have between 30 to almost 50% of the patient at 3 years that will have progressed of the disease. And it's very, very important to have those numbers in mind when you look at the radiochemotherapy cohort. So is radiochemotherapy efficient to treat bladder cancer? And the cohorts I'm showing here are T2 to T4 N0, all comers. This is not highly selected modality therapy trials and cohorts. It's any patient with a T2, T4 that comes for the treatment of the bladder cancer. This is the BC 2001 trial. This is all prospective data, very high quality. It's not retrospective cohorts. And when you look at this cohort that compared radiotherapy to chemo-radiotherapy, and the conclusion of this trial was that you should never do radiotherapy alone. You need to do chemo-radiotherapy. It's almost 500 patients with very long follow-up. The overall survival at 5 years was 49%, specific survival 63%. The invasive local regional control was 79%. And the radical cystectomy rate at 5 years was extremely low, only 14%. With less than 10% of serious toxicities. And keep in mind that the median age of the patients in the radiochemotherapy cohorts is much higher than the median age of the patients in the neoadjuvant chemotherapy plus cystectomy prospective trials. So it's completely normal that the overall survival is a little bit lower because the patient age at the inclusion is generally up to 5 years higher than in the neoadjuvant plus cystectomy cohorts. And this is very important when you look at overall survival data. Then you have the pooled analysis of the RTOG. This is 6 prospective randomized trial of radiochemotherapy. Again, very high number of patients at the end. It's a meta-analysis, 468. Long follow-up, 5-year overall survival is exactly the same than the one observed in the Grossman trial for neoadjuvant chemotherapy. It's 57%. And you have a 5-year bladder intact disease-free survival of 56%, with almost all patients recurring having non-muscle invasive disease, and only 13% of muscle invasive disease at the end. So those 2 trials tell you very clearly, in a very strong methodological prospective trial way, that radiochemotherapy is absolutely efficient for local treatment of bladder cancer. And this is not the future. This is the past. This is past evidence. Then, obviously, there are variables that are associated with survival. They are associated with survival in the case of radiochemotherapy. Some of them are also associated with survival in the case of radical cystectomy. You've seen on the curves in the previous presentation, patients that have advanced tumor that do not respond to neoadjuvant chemotherapy do very badly. This doesn't mean at all that you should treat them with radical cystectomy. They will do very badly whatever local treatment you do. But in the case of radiochemotherapy, it's very important to have a complete TURBT. It's a major prognostic factor. You should avoid doing it in patients with hydronephrosis, and it does better in patients with T2 compared to T3, T4. But this is exactly the same with radical cystectomy. If you perform a radical cystectomy to a T4, even after neoadjuvant chemotherapy, the patients are not going to go and do very well in the future. For CIS, it's a little bit more controversial. You should avoid doing it in diffuse CIS, but if you have just CIS around the tumor, it is probably not a major problem. So it's all a question of patient selection. And for bladder preservation, the better preferred or ideal patients are the ones that were on my first slide on the left, the T2, no hydronephrosis, no CIS, unifocal. These are the ones that are the most likely to have complete response. But you have very strong data to treat patients with radiochemotherapy, even in all comers T2 to T4 bladder cancer. But complete response is very, very important, whatever the kind of treatment you perform. And we have the data again from the RTOG meta-analysis. Look on the right at the blue curve, the complete responders. If you perform radiochemotherapy in patients that are complete responders, meaning that they had complete TURBT, there is no residual tumor after the radiochemotherapy, in that case, you're going to have disease-specific survival that is going to be over 85% at 5 years, exactly the same than what you have in complete responders after neoadjuvant chemotherapy and radical cystectomy. And if you want to obtain histological response, complete response, because we're saying that complete response is extremely important if you perform radical cystectomy or if you perform radiochemotherapy, the best way to obtain a very high histological response is through neoadjuvant chemotherapy. Because even with complete TURBT, most of the time you still have some urothelial carcinoma cells in the bladder. And so the best way to have histological complete response is through dose-dense MVAC. You're going to have 42% of the patients with modern neoadjuvant regimens that are going to be complete responders. So it makes sense to give the patient neoadjuvant chemotherapy, whatever local treatment you are going to perform at the end, because this is the best way to obtain a complete response that is a major prognostic factor. So if you want to look a little bit at the recent cohort, looking at radiochemotherapy in patients that had previous chemotherapy, so neoadjuvant chemotherapy, you're only going to have some retrospective cohorts. So I don't really like looking at retrospective data in this setting because it's highly, highly biased. but I had to show you the series from Zlota because it was discussed a lot since ASCO GU this year. It's a retrospective matched 3-to-1 study of more than 1,000 patients. And these patients are patients that were highly selected. So unifocal, no CIS, less than 7 centimeter, T2, no hydronephrosis. So again, the patients on the left of the first slide, highly selected patients. And 60% of them had neoadjuvant chemotherapy. And for those patients, you get extremely high 5-year survival probability with overall survival in the chemo-radiotherapy therapy group of 85%. And I'm not talking about the comparison with radical cystectomy because, again, I think we cannot really compare those patients in retrospective cohorts. But clearly, there is no major toxicity, no major signal for putting the patient at risk, since when you see this kind of overall survival, 85% in this cohort of more than 1,000 patients. And even for locally advanced tumors, we had this very recent series from Swinton. This is completely different setting because these are patients that had clinical node-positive tumor. So it's 2,087 patients. It's the largest clinically node-positive series published in bladder cancer. And those patients had first-line chemotherapy, and then they were treated either with radiochemotherapy or radical cystectomy. And again, this is retrospective. But what you can see here, again, is that there is no safety signal regarding treating the patient with radiochemotherapy rather than radical cystectomy, even in the setting of a locally advanced tumor. So the choice of radical treatment showed no association with overall survival. And then you have the Galsky phase 2 trial. Here it's all in to obtain complete response. It's chemotherapy plus neoadjuvant nivolumab, so chemotherapy plus immunotherapy. Again, the more systemic treatment, are given to obtain complete response. This is a small trial with 76 patients, but all were restaged after induction treatment. 43% of the patients achieved complete clinical response. All of them decided to not go for immediate cystectomy because this is what happens if you give the patient the option not to go for radical cystectomy. And again, look at the blue curve. This is the overall survival curve of those complete responders after first-line systemic treatment. It's extremely high. So we are in a situation where there is clearly enough evidence to say that treating a patient with radiochemotherapy for a bladder tumor that is responding to first-line treatment is completely acceptable, and there is no sign that this is going to go to that the patient is going to lose any day of survival with this kind of treatment. So I will finish here trying to summarize what we know and what we do not know about bladder sparing. So we have very high level evidence for chemo-radiotherapy therapy as local treatment for muscle invasive bladder cancer outside of the setting of neoadjuvant chemotherapy. We know who are the good patients for upfront TMT. It's T2, small T3, unifocal, no CIS, no hydronephrosis. In those patients, complete response is of utmost importance through extensive TURBT, through selection criteria, but also probably through neoadjuvant chemotherapy. And so you do not want to deprive your patient of neoadjuvant chemotherapy because you want to go for bladder preservation. And this is usually what we do in clinical practice. So you do not want to do radiotherapy alone. You want to do radiochemotherapy. And salvage cystectomy is going to be quite a rare event. Less than 50% of the patient will have muscle invasive local recurrence requiring salvage radical cystectomy. What we do not know, well, there is no high-level evidence for neoadjuvant chemotherapy prior to chemotherapy therapy. In the RTOG trials, there were 2 of them that were giving 2 cycles of neoadjuvant chemotherapy, but there has been to date no results of any trial that has been evaluating the impact of modern 4 to 6 cycles cisplatin-based neoadjuvant chemotherapy prior to chemotherapy therapy. So this is what we're doing in daily practice because we want to obtain complete response, but this is done outside of a high-level evidence. And this is a problem that we need to solve in the future by building methodologically strong studies. We have no validated definition of complete response, and this is also a major problem. Doing just a TURBT is clearly insufficient to evaluate response. 30% of the patients that are complete responders on TURBT will have muscle invasive disease on the radical cystectomy specimen. There has been no study that has evaluated a combination of TURBT plus MRI, which is what we do in my practice, and has proven to be quite a valid option, but it has not been evaluated properly in clinical trials or prospective cohorts. And there is no high-level comparison of quality of life, because we imagine that patients with bladder preservation have better quality of life, but this is not completely true. There is a good treatment for each patient. The patient that go for bladder preservation, they will have very strong follow-up, cystoscopy, and non-muscle invasive recurrence that will need to be managed. And so it's very important to have in the future quality of life studies to compare patients according to the kind of treatment they received. Thank you very much.
Thank you, Alexandra, for this excellent presentation. So we have some questions, guys, for you. Maybe you can take it. And one is particularly interesting. We all know from the IMvigor study that ctDNA could be a good marker. And I think Antoine touched the point of the marker. What do you think about the use of ctDNA, which appears to be of utmost importance now with the level of ctDNA to avoid cystectomy? Do you think it could be a good way to monitor the good candidates who would be suitable for non I would say radical surgery?
Yes, actually, the MAINTAIN study has an arm in which they also isolated the ctDNA. It's from the Dierschot group in Aarhus. And they're actually analyzing now these data. And I think when you look at the previous work of that university, then it's very nice to see that in patients who have no ctDNA levels after neoadjuvant chemotherapy do perfectly. So yes, that would be a way to select those patients. And actually, when I was listening to Alexandra's talk, I must say, of course, the bladder preservation possibilities are there, and trimodality treatment is. But the figures I showed with the 7% added mortality is when you do active surveillance. So a patient had a complete response, and you do nothing locally, so on the bladder level. And in that sense, if you want to do nothing, if you want to follow those patients up and do active surveillance, I think you really need, besides imaging, besides an MP-MRI, and if you add at that MP-MRI, for example, an FDG PET, you should add something like ctDNA or DDR markers, because you have to prove it also in a liquid biopsy or in a normal biopsy.
Yeah, I completely agree that it's probably the most promising marker. What we don't know is how it's going to be predictive of recurrence or persistent disease in the bladder, because mostly it has been evaluated as associated with distant metastasis and progression of the tumor outside, since it's mainly in radical cystectomy specimen. And we don't really know now if this kind of marker are going to be useful in the setting of identifying potential residual tumor in the bladder after neoadjuvant chemotherapy. But still, the data from Aarhus is extremely nice, maybe even too nice to be true. The study by Dierschot is really interesting, and it's a very, very promising marker. We are looking forward to have more studies using it.
Okay.
And it's very laborious, that technique he uses, because it's a treatment and an analysis per patient. So it's not something you can do on a large scale in a daily clinical practice. That's also important to realize, that it's not a very easy technique to do in all patients, because you first have to sequence the tumor as well.
Alexandra, excuse me, we'll move on with another topic, because there are plenty of questions popping up. So Joan Cresswell is saying that you expose some convincing data for bladder preservation, but in the mind of many colleagues, bladder preservation is sticking with TMT protocol, 3-modality treatment, as a reasonable option in selected patients, as you mentioned in the beginning of your lecture. However, the question is, did you conclude that surveillance only after neoadjuvant chemotherapy is a safe option without proceeding to radiotherapy? Meaning that you would not only consider preserving the bladder, but changing a little bit the vantage point that we have from the regular, I would say, TMT modality.
Yeah, well, this is actually the field of bladder preservation is opening, and there are plenty of ways to preserve the bladder. You can preserve the bladder through just monitoring the patient, active surveillance. You can preserve the bladder with radiochemotherapy, and you have plenty of treatments that are being tested now in the setting of BCG refractory tumors, for example, that might be used in bladder sparing protocols. For example, the Sunrise trial with the TAR-200, but maybe also TAR-210, and what maybe not erdafitinib, but yeah, maybe intravesical erdafitinib or enstiladrin or whatever. Regarding for surveillance, there was a study conducted in France in the past year that was called RECHIVE, which was 6 extensive TURBT, 6 cycles of MVAC, and then new extensive TURBT. If there was no residual tumor, the patients were monitored. We will get, I hope, the results of this study next year. But from the centers that have been participating, they all have the same point of view. In those highly selected patients that had very, very extensive TURBT, monitoring, simple monitoring seems to be a safe option. And so I think the question is all about how sure are you that you have performed a radical cystectomy through an endoscopic way? Because when you have a 2-centimeter tumor that is a T2, if you perform a really extensive TURBT, there are situations where you are not going to have any residual tumor. And in my center, where we usually do re-TURBT for muscle invasive tumors, because we really want to be as sure as possible that we have resected everything, it's not so rare that when we come back after the first TURBT for a T2, there is no muscle invasive residual tumor on the second TURBT. So it completely depends on the size, the location, how extensive your TURBT was, the MRI, but there are probably patients for which active surveillance might be an option if you are able to perform extensive TURBT, because this is absolutely central. It's not just a biopsy that you are doing. You are really endoscopically resecting integrally the tumors.
So interesting, because both of you at the moment you touched the point of MRI, and MRI could be interesting not in following up on this patient, but also on deciding who is going to be the good candidate. Do you see, Tuan, that I think you were the first who said that MRI could be a useful tool? Do you think that with the VIRADs becoming more and more popular, that it is something that we should consider in our practice?
Actually, we do it now for 1.5 years. We scan nearly all patients with a muscle-invasive bladder tumor, and also during treatment, we participate in the CT0 study, for example, a combination of chemotherapy and immunotherapy. And MRI is absolutely superior in treatment response. Absolutely. Also in the detection of muscle-invasive tumors to select those with a T1 or T2 tumor. So yeah, I think that's the future, actually.
Alexandra, you are a very talented radiologist in your institution. How do you see the situation on your side?
Yeah, I agree. We started performing MRI 2018. And in my daily practice, actually, I don't really use the VIRADs on the daily point of view, because I don't find that this score is particularly useful. I do use MRI prior to TURBT because it's very important, to my point of view, upfront to select patient for potential bladder sparing treatment, because it's going to give you some evaluation of what is happening outside of the bladder, because with your endoscopic resection, you see what is happening inside. But when it comes to bladder sparing, you really want to know what's happening outside. Do you have a big T3? Do you have tumor in the fat? It gives you information also sometimes about multifocality, what happens with the meatus when you don't see it. So I think it's a very useful tool to give some information about the morphology of the tumor, to select patient upfront for potential chemotherapy therapy. And then I cannot work without it anymore when it comes to selecting patient based on response. So it's a very useful tool. It's not 100% sensitivity and specificity, but when you look at the literature, you have area under curves for predicting complete response that are between 0.83, 0.8. When you look at the PURE study, they have a very nice MRI part on the PURE study that was published in European Urology, and they were extremely good prior to radical cystectomy to identify with MRI alone the patients that were complete responders. So it has to be a combination of tools, clinical tools, cystoscopy, TURBT, MRI, maybe ctDNA, and we need to work on that and validate actually this definition to be able to go forward and select patient based on response.
Okay, coming back to pragmatic cases, there is a question about did you ever try neoadjuvant chemotherapy for a patient with a tumor inside the diverticulum? We all know that it is a tricky case. There is no muscular layer in the diverticulum. Have you faced cases of bladder tumor within the diverticulum? So I don't know if it's a subset of the patient, but we are going back to pragmatic daily cases.
Well, this person has not been listening to my clinical case because it was exactly what I showed. It was not one diverticulum. It was actually something like 4 or 5 diverticulum. There were a lot of them. So, well, to my point of view, those might not be the best candidates for bladder preservation upfront, because usually if they have a diverticula, it means that they have obstruction, they have LUTs, the bladder is not always very well functioning. It's very challenging to do complete TURBT. Well, there are a lot of reasons, but I don't exclude the patient radically based on that. I do my best to resect completely. And if the patient wants to go for bladder preservation, I will reevaluate after NAC. And if there is no residual tumor and the MRI is clean, then I will go for it. But I mean, in my center, we do a lot of those. We have experienced radiation oncologists. Probably those are not the best patients to select if you want to start with bladder preservation strategies.
Juan?
Yeah, I do agree. But I think when it's a very large tumor site with tumor in the diverticulars, probably that might be a candidate more for a cystectomy, but that depends also on the wishes of the patient. It's a shared decision making, I think.
So we have a good question from Professor Xilinas, who is connected. That's nice. What about bladder preservation in patients who progress after the high-grade non-muscle invasive bladder cancer setting?
That's a tricky one.
Yeah, that's the worst part of patients, I think, and the most risky one.
Yeah, so
I first would know for sure that that patient doesn't have CIS, and if it's only a small T2 tumor, then it might be an option. But I think you have to be very aware of more extensive disease and more field changes and heterogeneity in the bladder in those patients.
Okay. Alexandra, same thing?
Yeah, I completely agree. I think that that the fact that the patient is progressing is not itself a problem, but usually those patients have multifocal disease, they have CIS.
Yeah.
We know that when you perform radical cystectomy for those patients that progressed after BCG, you have a very high rate of T3, T4 diseases, node-positive diseases. So yeah, you should be very careful. But again, this is not a criteria that has been published. It has not been validated. In the True Modality radiochemotherapy series, they usually do not describe which part of the patient were progressive disease compared to upfront muscle invasion. But stick to the criteria. If you have multifocality, if you have CIS, if you have locally advanced, not good candidates.
Okay. What is the proportion of cT0 status after neoadjuvant chemotherapy in your own experience?
About 30-35%.
Okay. Alex?
So in Saint Louis, it's 50%. We have the numbers, we've looked at it, but we don't have as I've told you, we have a very extensive TURBT strategy, and we do second looks, which is not at all standard of care. And I'm not saying that everyone should do that, because we actually do not know. We have not evaluated the association with survival, so it's not validated. But if you use complete response as a surrogate endpoint, performing those very extensive TURBT plus second look whenever needed allowed us to get a 50% complete response rate. We perform only 6 cycles of MVAC, but I mean, Stefan Kulin, who is the last author of Vesper, is the oncologist in my department. And we see that our numbers are a little bit higher than what was published in Vesper trial from other French centers. And I think it's just because we are resecting very deep and we are going back.
Yeah, the second resection will make a big difference, I think.
Sure.
Yeah.
And we do it because we want to offer the more patients we can bladder preservation. So we won't do it in the case where we know that we were going to go for radical cystectomy.
Yeah, that was actually my question. If you know a patient go for cystectomy, you don't.
No, but in my experience, there are quite a lot of patients that are candidates for bladder preservation. So we do as much TURBT as needed. I mean, we do not select based on the size itself. We select based on our ability to completely resect. So if it's 6 centimeters, but in 2 times it's completely resected and there is nothing left, we will not exclude the patient from bladder preservation based on the size, for example.
Okay. So one last question for you guys. What type of radiotherapy for those who are doing TMT do you recommend for candidates of TMT?
So none of us is radiation oncologist, I think, but it's an evolving field. And the radiation oncologists are telling it themselves. They are really moving in that field at the moment. What we do in my institution is that we do bladder plus pelvis. There was one randomized trial that is not very high quality, but that showed better results if you do pelvis plus bladder. So usually this is what is done in the cohorts, but this can be discussed. And we used to do 60 gray, and we are now reducing the amount of rays that are given to the patients. The bladder has to be, it's very difficult you need to control the bladder filling. It has to be between 250, 300 milliliters. It's not easy. And when you look at the cohorts of radiotherapy for bladder cancer, you can see that the rates of radical salvage cystectomy are decreasing a lot with time, and radiation oncologists are getting better and better. And so there are a lot of trials that are ongoing to test different kind of radiotherapy regimens and boosts on the tumor bed and so on.
Okay.
We do it actually more or less the same, but we give 55 gray and we do a tumor boost. So we mark the tumors before with Lipiodol or BioX mark, and we give a boost on the tumor and the whole bladder a lower dose. And that hyperfractionated schedule that's more and more coming up nowadays. So, and we will start within, I don't know, within maybe half a year or 1 year with the MR LINAC protocol. So the very high dose focused hyperfractionated bladder schedules.
Okay, perfect. I think we will have to close this discussion. It was a pleasure to share this webinar with you guys. I would like to thank the ladies from the office, Tessa and Yorgita, who organized everything. We had more than 200 participants and lots of interaction on the Q&A. I think the take-home message is quite clear. It is no one size fits all, and we need to go into the direction of personalized medicine. And when it comes to muscle-invasive bladder cancer, there is room for improvement, and probably some patients at the end of the road could ultimately keep their bladder regardless of the stage they are diagnosed with. But we need to have the appropriate tools for the selection of these patients. So we are working on that, developing clinical research, clinical trials, and we keep following on this topic. I would like to thank the school who is organizing the webinar, the European School of Urology, together with the section of oncourology, which I'm honored to chair. So I would like to thank you. Have a very nice evening, and see you soon on all the channels of the EAU. Bye-bye.